When we think about the pandemic and the restrictions on dental services, I think we in Victoria are very qualified to have an opinion about the effect of COVID-19 on dentistry, having endured 6 lockdowns. One thing that I think is less obvious is the effect of the restrictions on prescribing. And after all, we were only really advised to suspend routine dental care, procedures that were not urgent and that could be delayed. And so we could play our part, of course, in minimising the movement of the public during that time. However, we have found that restrictions of dentistry does result in altered prescribing. So we conducted a survey of dentists in Victoria that was supported and facilitated by the Evident Foundation about prescribing during the pandemic. This survey was actually conducted in other parts of the world, so England, Canada, and the United States. Results in the US and Canada are still being finalised, and so today I'll present results from Victoria, Australia, as well as England to understand the effect of COVID-19 on dental antibiotic prescribing. The data in this presentation in relation to the Australian data was collected as part of the Evident Project 029, and the information presented is the opinion of the team. Antibiotic prescribing is important in the context of antibiotic resistance. The global public health problem, antibiotic resistance, develops and spreads by so many factors. Antibiotic use in aquaculture, agriculture, in our farming, soils, wastewater treatment, and of course, not to mention spread by humans and animals, all contributes. Of course, antibiotic use in healthcare is a major factor, and this, of course, includes dentistry. How much does dental prescribing contribute to all prescriptions? Well, dental antibiotic prescriptions contribute to an estimated 10% of antibiotics worldwide. However, up to 80% of prescribed antibiotics in dentistry are actually inappropriate for both prophylactic and therapeutic reasons. One of the key differences between dentistry and some aspects of medicine is that antibiotics are generally only adjunctive to dental treatment. And of course, in Australia, our guidelines focus primarily on the 3 Ds, the correct diagnosis, then dental treatment. Because as we all know, with an accurate diagnosis, active dental treatment is the quickest and most effective way of treating dental pain and infection. And drugs are last and are only adjunctive. But when antibiotics are needed in dentistry, we really need them to work. If a dental infection hasn't been managed effectively and spreads, a patient can end up with a spread infection, like in the photo, which is a medical emergency, as the infection, of course, has spread and causes swelling of the neck and airway. Antibiotic resistance is therefore very important for dentistry. Spreading dental infections such as this one can be life-threatening. The first clinical failures for penicillin therapy for dental infections were described in 1983, where strains of the Bacteroides species that produce beta-lactamase were isolated from each of the 5 cases of ineffective penicillin treatment. It has shown that resistance to penicillins on odontogenic infections does vary worldwide. Here in Australia, around 11% of severe tooth infections in the South Australian population were resistant to penicillin and 13% resistant to multiple antibiotics. And these infections that were resistant to antibiotics were associated with poor clinical outcomes and longer hospital stays. Appropriate use of antibiotics in dentistry therefore plays a role, a really important role, when it comes to antibiotic stewardship. So here in Victoria, between 2020 and 2021, we had 6 lockdowns. And it's amazing that I remember going through all those lockdowns so profoundly at the time, but now they've kind of all blurred into one. But during the time of restricted movement of people and restriction on services, we also had a restriction on the provision of routine dental care. And our recommendations on treatment procedures came from the Australian Dental Association, as we know, and it was generally what we called level 3 to 4 restrictions, depending on the lockdown, depending on the time. And most of the advice centred around limiting the production of aerosols, of course, in order to limit the unnecessary movement of people. So emergency treatments for trauma, they were all permitted, and most management of acute dental pain could take place using rubber dam, but all routine treatment was to be deferred. And as a result, many practices shut or significantly reduced their hours of operation and staff, since there was no provision of routine care. So we looked at dental prescribing during this time, just for the first nationwide lockdown that occurred between March to May 2020. And when we look at antibiotic prescribing in Australia, we noticed that there was a drop in the antibiotics prescribed during April, but a significant and steady increase in the use of antibiotics in June 2020, and that's when we were all let out of lockdown. In fact, when we compare June 2020 to June 2019, there was a 10% increase in the use of antibiotics, and particularly the broad-spectrum antibiotic, amoxicillin with clavulanic acid, that increased by 20%. And that antibiotic is actually third line in our guidelines because it is, of course, broad-spectrum and therefore contributes more towards resistance compared to narrow spectrum agents. But interestingly, we did see a large increase in the use of that particular antibiotic. And so during the pandemic in England, because we'll be presenting English data as well, dental practices in England, in the UK were mandated to temporarily stop routine care between March and June 2020. And during this time, guidance from the NHS in England regarding the management of urgent dental conditions recommended the adoption of what they called AAA regimen: advice, analgesia, and antimicrobials where indicated and where appropriate. And general dentists were permitted to do telehealth and conduct triage and assessment by telephone, and then to manage patients accordingly. When the AAA regimen was then considered ineffective, that's when general dentists were then advised to refer patients to locally established urgent dental care hubs for active dental treatment. Because of the lockdown and the nationwide effort to minimise movement of people and transmission of COVID-19, the AAA regimen then provided a means to manage dental conditions and, of course, permitted prescriptions of courses of analgesics and antibiotics for the temporary relief of symptoms. And this was important for them at that time because there was a limited number of urgent dental hubs and some uncertainty as to the timeframe and locations from which patients could seek appointments. And so given these changes in the provision of dental services and suspension of routine dental care in both locations, as well as the changes in the trends of antibiotic use, my colleague and I conducted similar surveys in both locations, England and Victoria in Australia, about antibiotic prescribing during these periods of lockdowns. So with the survey in Victoria, we distributed surveys to Australian Dental Association Victorian branch members. We had 108 completed surveys, so a bit less than England. And while the dentists had a relatively even spread of years of experience, 80% were from practices in high socioeconomic locations and mostly from private general practice. Given the suspension of routine dental care and only being able to treat emergency patients, 61% of the dentists saw 25% of their regular workload and 23% saw 50% of their regular workload. However, 35% of dentists prescribed more antibiotics compared to the same time in 2019, despite seeing less patients. And 40% prescribed about the same numbers, but again, most still saw less patients. So while 37% of dentists did not prescribe antibiotics to delay treatment, 63% actually, they did prescribe antibiotics to delay treatment, with 20% in total, not of the 63%, prescribed antibiotics every 5 patients or more frequently for the same reason. When we look at other factors that influence prescribing in Australia, it's interesting that factors that related to knowledge and skills of the dentist that influence antibiotic and opioid prescribing, we actually looked at both antibiotics and opioids in this particular survey. They weren't really that different during and prior to the COVID-19 pandemic. So skills to cope with running late, skills to deliver treatment, knowledge about the risks of these drugs, and guideline influences that didn't really make much difference whether the pandemic was around or not. But almost all workplace factors really affected the dentist's ability to perform treatment. So patient requests, ability to follow up patients appropriately, their healthcare system. So what dentists were actually allowed to do in terms of performing treatment and providing appropriate care, accessing routine and specialist care, and just being able or not being able, I suppose, to provide face-to-face care really affected the dentists and dental specialists when it came to prescribing antibiotics. And we didn't have a lot of telehealth here in Australia compared to England. So that last factor, access to remote care, as in telehealth, didn't really affect prescribing. And so now to the English data. So again, the same online survey was distributed to dental practitioners in England, and they received 159 completed surveys, a bit more than us, and 41% of dentists having graduated between 2010 and 2019, again, mostly general dentists. Around half the respondents felt the guidance provided by the NHS regarding the AAA regimen was somewhat clear, with 9% actually finding the guidance extremely unclear. Unsurprisingly, 89% of the respondents prescribed more antibiotics during the pandemic compared to pre-pandemic. But what was surprising was that 35% of dentists had their referral to urgent dental centres for patients who received treatment rejected because a patient had not first taken antibiotics. So the system was that they had to have tried antibiotics to their patients first, despite the fact that we know antibiotics doesn't cure toothache, and definitive treatment is needed to solve dental pain and infection. And What was also interesting with English data was that after practices reopened, 23% of dentists continued to prescribe antibiotics remotely to avoid an aerosol-generated procedure. And a year later, 8% were still doing so. And this is in April to September 2021, despite at that time, that's when treatment could then be performed. So I think the qualitative part of this survey was probably the most interesting section from the English data, as it really captures the pressures and the issues that dental practitioners faced while trying to treat patients with respect to guidance, as well as prescribe appropriately. And so these comments came from an open-ended question at the end of the survey saying, is there anything else that you would like to tell us about prescribing during the pandemic? We had no comments on the Australian data. So the first quote that I have up on the screen, patients will refuse to be seen at an urgent dental centre until they'd had antibiotics. And the second quote does also echo the first regarding prescribing before they were seen by the urgent dental centres. It was just prescribing for no reason. Urgent centres wouldn't take patients. They would reject them if antibiotics hadn't been given. I had to prescribe for a loose tooth as they wouldn't see the patient otherwise. And the third quote I put up refers to trying to avoid an aerosol generating procedure, but also the effect of chairside staff. Biggest barrier was the unavailability to do aerosol generating procedures. Nurses were also a barrier, as they wouldn't agree to run 30 to 60 minutes late to see a patient in pain. However, dentists in England, I think, really are aware of prescribing the effects on antibiotic resistance. And these next two quotes on this slide really echo that, as well as, I suppose, the sense of frustration that one can hear from these comments regarding how these dentists had to manage patients during the time. And they felt they had no choice in clinical decision making, and they were aware about antibiotic resistance. So the first quote, I lied a lot. When patients had pulpitis, I told them to say that I prescribed antibiotics as a means of being seen at the hub. Antibiotics would not have been appropriate. The next quote, I feel horribly compromised as I feel this is far from ideal and I worry about antibiotics. And the last quote, I think, really captures the frustration of dentists having to prescribe and not being able to do treatment, but I suppose also the complexity of the situation. Because at the end of the day, antibiotics do not cure toothache. People end up returning in pain as they've been given antibiotics instead of procedures. I felt that the AAA guidelines went totally against all I've been taught about treating dental pain, but I felt I had no choice but to prescribe antibiotics on many occasions, as we were not allowed to treat patients face to face. It was a very difficult situation. So the survey captured a really interesting snapshot of the pressures and other factors that influence antibiotic prescribing by dentists during the pandemic. So these surveys of dental prescribing during COVID really make it very clear that reduced access or suspension of routine dental care procedures, so procedures that are not considered to be urgent, are associated with an increase in the use of antibiotics, and that workplace factors such as time limitations, policies that are put in place on referral patients who can receive treatment, restrictions on procedures and patient expectations, they all influence antibiotic prescribing decisions. And at the end of the day, I think it really highlights the importance of dentistry. So that routine dental care, from doing our simple and not so simple fillings, providing oral hygiene advice, access to fluoridated water, tooth cleaning, the very core of dentistry is so important to tackling antibiotic resistance. It's when we have less tooth decay in gum disease, we have less chance of infections, and when there's reduced infections, there's less need for antibiotics. So the provision of routine dental care, what dentists do every day, is so important for us when joining our healthcare colleagues in tackling antibiotic resistance. Of course, I would like to acknowledge my co-investigators, Dr. Marietta Taylor, Professor Michael McCullough, and Associate Professor Matthew Hopcraft, as well as, of course, the Evident Foundation for their support in facilitating this research. Thank you very much.